Greetings. Welcome to SADS Live 118. Great to be with you on this Friday, May 12th, as we come upon probably, I think some of you out there will agree, one of the most important Sundays of the year, Mother's Day. Happy Mother's Day to all of you out there. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and our Winland Smith Rice Sudden Death Genomics Laboratory. And it's on behalf of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, and our CEO, Alice Laura, that we're here together. I've had the privilege of serving as the board president of SADS now since 2006, believe it or not. And now since March of 2000, we've been together on a lot of Fridays, 118 of them. In fact, I guess one Thursday, didn't we? We did a Thursday, but it's great to get to be with you and to take your questions. Again, we were supposed to have a surprise visitor today join me, but he no-showed on me. I won't reveal his name or his initials, but so you're stuck. But I hope you'll enjoy it. I love Question and Answer Friday. I love your questions. Invariably, they generate a new project for our lab, a new question that needs to be answered that hasn't, where the answer isn't out there to your satisfaction or to my satisfaction. And so I love your questions, and hopefully you've enjoyed my attempts at an answer. Remember, I never give specific recommendations for you as a specific patient, because obviously without you being my patient and sizing up the data and the story in a true patient-physician relationship, I cannot do that. So don't take my comments or responses as directing your personal next step. I think you know that, and I guess we just give that disclaimer. What are we up to as your questions come in? Remember, we have an upcoming thing in 4 days, Tuesday, May 16th. I wish I could join it. It is the Parents of Teenagers webinar, Tuesday, May 16th at 7:30 p.m. Eastern Time. With it, the SADS group, Aaron and Anna and team, Marcia, have assembled teenagers, young adults, with almost all of the genetic heart conditions represented to be there and to take the questions of the moms and dads, the parents. So that would be great, and I'm looking forward to that. And as we come together next week, the reason we're doing 2 weeks in a row is because next Friday, next Thursday, in fact, many scientists, physicians, clinicians, heart rhythm specialists from all over the globe will be convening at Heart Rhythm Society in New Orleans for its annual meeting. And that is where a lot of content and updates and advances for your genetic arrhythmia syndromes, your cardiac channelopathies, your cardiomyopathies, where there may be electrical risk or risk of electrical agitation, so we say, we call that arrhythmias, and for the possibility of a dangerous, life-threatening arrhythmia. So those we will be convening. We have from our program, the Winland Smith Rice Sudden Death Genomics Laboratory, I think we're presenting 15, maybe more presentations and posters. I will be giving as part of the SADS Foundation program on Sunday, right before I fly back home, an update on our unique and proprietary gene therapy for long QT syndrome and how are those wasco wabbits behaving. I'm excited to give everybody at Heart Rhythm Society that update. It's going to be a lot of good content, and then we'll give you an update and a debrief of maybe some of the highlights from that meeting relevant for your family's conditions. Well, with that, questions have started to come on in, and we have 35 minutes on the counter to look at the sidebar and take them in order. So there's been no preparation, as you know, and that's why sometimes you have stumped me. So I don't know if one's going to come in from Julie, but just in case, This is for Julie again. Pretty nice. Thank you, Julie. I love it. And sometime I will have the author of the book, The Girl Who Played Hockey, and her, the athlete herself, join our program. And maybe we can have her and Alexis, recent world dance champion, her and her mates. And maybe the reason behind that Baylor University Championship, have him join us and have a collection of athletes at elite levels who are living and thriving despite. I would love to have that interview with them and have them join us for it. But I've got work to do to get them scheduled. So Krishnan, you get the first one. And you are reminding me that I said once that Dr. Wilda, Arthur Wilda, and I were going to write a review paper on beta blocker side effects in long QT syndrome. Yes, we did publish that. I'd have to find that paper. It wasn't with Arthur. It was a paper that we did with my program of the, now I've had the privilege of caring for over 1,600 patients. Some are here on the call with long QT syndrome, and really putting out sort of all of the laundry. What's working with our therapies? What are the unwanted side effects? What motivates me to be dissatisfied with the status quo, and trying to come up with new ways to treat your conditions rather than just saying the current therapies are good enough. Yes, they are good. They're great, in fact. Tragedy, sudden death doesn't happen, but we long ago in our program have moved the goalposts. The goalposts are not to prevent disease-triggered sudden death. We almost always succeed with that. The goalposts are now living and thriving despite your condition. Better quality of life on therapies, less complications from therapies, less side effects. Now, most the side effects of beta blockers, many patients and families tolerate their beta blocker beautifully. And so don't be wondering when you're going to start to feel side effects if you're not. Many have no side effects. Our program is biased because we get an enrichment of patients and families who have concluded they do not like their therapy, their beta blocker, their side effects, and then they're seeking alternative strategies. So overall, beta blockers well tolerated, but it's those who are not tolerating it, those who are the self-declared beta blocker zombie. You are my why. You are the reason why we are not satisfied with status quo, and we continue to strive to find new therapies. Very exciting on the new therapy front is we will likely be enrolling the first patient later this summer to receive Thrive Therapeutics' new drug for long QT syndrome. And we already have a meeting convened with the FDA later in June of this summer to understand the roadmap towards its approval should we meet all of the efficacy and safety endpoints. This is super exciting because it would represent the first drug, if it works, to receive FDA approval where the indication is your disease, congenital long QT syndrome. Stay tuned. We'll keep you updated on that. Full disclosure, I'm involved. And so, but you'll get complete transparency from me because first and foremost, you, my patients, are what matters. So that's that one. That was a long one for you, but thanks, Krishnan, to kick it off. Then some updates from the SADS Foundation, and then from Christine. Her son is 12. I love that age. And he'll have his current dual chamber epicardial pacemaker for hopefully 15 years, but we're wondering about leadless for the future. Great question, Christine. We had a program a while ago. Maybe it's time to bring him back from a member of our board of trustees, Dr. Charles Barul in Washington, D.C., gave us a view of a sort of the futuristic view of where our device is going. Will we be at leadless defibrillators? Probably not by then. Leadless pacemakers in that body size? Probably yes. Smaller and smaller defibrillators? Getting smaller, but we're kind of at a size that's limited by waiting for a next level battery breakthrough or a capacitor breakthrough. New ways of installing the device. Yes, we have a new one advancing from Medtronic. It's a so-called endovascular ICD. The Boston Scientific subcutaneous ICD or SICD. There'll be next generation getting smaller with that one. For our elite collision, no, you don't even have to be elite. For our collision sport athletes and for those who don't want intracardiac hardware, we also use a strategy at Mayo Clinic where we hide the standard generator under the rib cage, and then we make a small incision underneath the breastbone, and then we attach the lead to the back of the heart. We call that the epicardial ICD. That's what we use when you have to install it in a baby, because that's the only place to place it. But we've used that now, not for just babies, children, adolescents, young adults, athletes, collision athletes, models who want to hide their device and so forth. So a lot of progress, a lot of options even right now, but there'll be even more for that. Malia, should I be concerned about having a large U wave and a short PR interval in the setting of long QT syndrome type 1? Never been symptomatic, diagnosed at age 37 after discovery in your 2-year-old. So your son, 2 years old, gets diagnosed first, gets genetically tested, finds the LQT1 causative variant, and now you have it, and she's sharing that her ECG is showing some other things. And the other things is a U wave. And so the U wave, the issue with the U wave is in some situations, it could falsely elevate the impression of the QT interval. So whenever we have a U wave, the team is carefully dissecting out the end of the T wave, QT interval, to make sure we don't include the U wave, QTU. And so that's the problem. The short PR interval probably for sure doesn't matter. There is an entity where if there's a short PR interval and a so-called delta wave, that could suggest the presence of pre-excitation. The combination of pre-excitation with a short PR interval and a delta wave and LQT1 is super rare. So it may, in that person's situation, may not be relevant, but that's what I would be doing and what any heart rhythm specialist would be doing when they're staring at the U wave. Mark is asking, are there additional precautions for taking our LQT3 daughter now that she's reached puberty? No, just puberty. That brings a life of its own on, but remember, everything is perspective. For my wife and I, we refused to call the terrible twos the terrible twos. They were the terrific twos. We've refused to call the terrible teens the terrible teens. We called it the terrific teens. And our 4 children now, with only one teenager left for one more month, all otherwise in their 20s, and even our oldest, now 30. They did not disappoint. So it's a great transition for your daughter. Is there higher risk for females after the arrival of estrogen for long QT 1, 2, and 3, or long QT syndrome in general? The answer is yes. Compared to girls before puberty, young women after puberty have more events. So it's a higher risk window of time. I do not like calling it high risk. I think that misrepresents the transition. So I don't view this as spooky or fragile. What I generally do when a girl transitions into and through puberty after the 3rd menstrual cycle, if I have not seen them in terms of sequence of their follow-up, just get an ECG to see if the QT has reacted to the arrival of estrogen and move them from their QTC value to a higher QTC. Sometimes yes, sometimes no, doesn't do it. And then I just make sure, based upon what is their QTC, as to how aggressively I treat. So for example, whether they're a girl or a woman, if the QTC is above 500, I need to have game on. I need to really do everything I can. And in the case of LQT3, we have medications besides beta blocker, particularly mexillatine, to intentionally try to make the QTC look like mine, to lower the QTC. And that's exactly what mexillatine does. And we know from work long ago from a good friend of mine, Dr. Sylvia Priori, I've had her on the program, that when we make the QTC shorter with mexillatine in LQT3, we provide therapeutic benefit. We provide measurable protection. So not too many precautions, just making sure that the treatment's in good shape. And an Instagram question. Oh, speaking of Instagram, before I get to your question, you should check out on Instagram, and I got to remember what my wife's, oh, I don't know if I'm going to find it in time. I think it's Green Lake Mom. Green Lake Mom, because she posted an amazing reel of our son, and his first solo flight. Our second son, Nick, he is inspired by little sister, not so little. Okay, she's 19, turns 20 next month. But if you go to Instagram and go to, I guess, is it at Green Lake Mom? You would see a really cool reel. So follow my wife. She would love that. And then you can sort of keep up of some of our life story. Yeah, I think it's Green Lake Mom. But anyway, on Instagram, sorry, I digress. Our exercise restrictions a normal part of the treatment strategy for Brugada? No. That's a great question. It is so worn out by physicians where you get diagnosed with whatever and you get disqualified or you get restricted from exercise. There is no evidence that exercise precautions or exercise restrictions are necessary in Brugada syndrome. Never has been. The only precaution that you could extend from exercise is, well, what if you overheat in sort of 2-a-day summer practices in deep South Alabama where it's really hot or whatever? And could you overheat? And could that overheating or rising of your core body temperature aggravate your Brugada? And because of that, we just say, you know what, let's be careful. All of us should avoid heat stroke during training sessions or heat exhaustion or overheating. And all the more important for somebody with Brugada. But no, all of my Brugada patients who want to be an athlete, they are athletes. Beatrice is from Switzerland. Oh, Beatrice, I can't wait to come to Switzerland in December, bringing my daughter, then will be 20, to join my wife and I in one of our favorite countries in the world. And Beatrice is writing about her 12-year-old son, was found to have a prolonged QT interval, mentions it to be above 520. If that's correct, that's a long QT interval. And immediately placed on core guard, Nadolol, since he plays football. Now the max QTC is around 490. He did genetic testing and surprisingly found him to have a different gene, not long QT syndrome. The plot thickens here. Something called TNNI3, that's usually associated with hypertrophic cardiomyopathy. Already had done 2 electrocardiograms, echocardiograms, but doesn't show anything. Have I seen cases like this before? Wow, that's a good one. So we and others have published about TNNI3 mediated disease. And again, if TNI3 is troponin I, that's the gene that encodes troponin I, that almost never shows QT prolongation. So I'd be curious, the curious person in me when I'm faced with that would be to say, okay, do we have two things going on? A TNI3 variant, is that a true disease variant or is that noise, a VUS? Uh, did they do genetic testing that included the long QT genes? I bet so. They're great in your country, the genetic test companies. But right now, we don't have things that fit. So when things aren't concordant, when things don't fit, I kind of go back to the drawing board of the detective work and say, what am I missing? What's not making sense? What's not fitting? And so I think there's detective work to be done in that situation. I would make sure, do I agree with the QT measurement? Is there really QT prolongation? The reason I'm showing a little skepticism in that sense, not knowing anything about who's the doctor or whatever, is we at Mayo Clinic have removed the diagnosis of long QT syndrome in now about almost 500 patients. I don't know if we've hit 500 yet. And in those 500 patients, the number one reason for overdiagnosed long QT syndrome is a mismeasured QTC, an ECG that was erroneously interpreted, where the QTC was erroneously overcalculated. And so that's our number one reason. Number two reason would be a non-QT faint, vasovagal, normal, lightheaded, syncope, fainting. But then somebody gets an ECG and the QTC is borderline, and then they get called long QT syndrome. Game, set, match, diagnosed, as opposed to slow down, maybe not. And so I would say work needs to be done. Nicole is asking, have I worked with LifeSure for patients trying to get a home automatic external defibrillator? Great question, Nicole. Yes, I have. I'm not on their board. I'm not involved with LifeSure financially in any way. LifeSure is a for-profit company that advocates and does interference with your insurance plans to help you, the family, secure an automatic external defibrillator as part of home safety gear. They are amazing. In fact, this is probably a setup for me, Nicole. When we get together again in, wow, I guess it's going to be 3 weeks from today, on June 2nd, that is CPR AED Awareness Week. And I hope we get a representative to join me from LifeSure. That's the plan. We've had Adrian and others join me in the past and would love to do so again. I use them routinely for all of my families. Now, again, I do recommend an automatic external defibrillator for my kids with long QT syndrome, CPVT, who are treated, who don't need an internal defibrillator as part of safety gear. Now, one of the reasons why it's sometimes hard to get one is because you almost never need it. And we've published that. So insurance companies say, why do we need to give you this? It doesn't look like there's medical necessity. So in my 23 years, over 700 kids with long QT syndrome under my watch, probably 800. We have never, as in never, had an AED rescue shot given or needed or wished for any of my LQT1 kids ever. And for the LQT2 and LQT3 kids, 4 times in 23 years. So they're almost never needed. So it's safety gear, like my fire extinguisher is. I have one. I know where it is. I know how to use it in our house, and it's never been used. Same mindset for the AED. So, but sometimes your insurance company's medical equipment plan does not pay or refuses to cover it, saying it's not needed. And that's where LifeSure does an amazing job to do battle with the insurance company to say, wrong answer. try again, and they get the correct answer, as in successfully securing an AED for your family, a lot. And I would, in my experience, it's been at least 90 to 95% success rate. So thanks for the question, Nicole. Oh my, I got behind here. Speed dial now. Sometimes those your questions are moving to the long side and slows me down. But Kate's asking, are loud noises, dog barking, alarms no longer something to be concerned by if an infant is treated with their Nadolol beta blocker? You have twin infants and get so nervous they'll be startled, including the screams of each other. I love your question, Kate, and I think maybe we haven't done a great job of conveying this, because I think our over exuberance of noise reduction and startle reduction has been a bit misleading. Yes, we know. What do we know? We know that alarm clocks can be triggering. We know that noises can be triggering, and that auditory trigger is most often for LQT2 people as the trigger. But that most often for LQT2, we should be qualifying, and that is almost always when you were untreated because you were not yet diagnosed, and that's how we then discovered your long QT syndrome, found it to be LQT2, treated you well, but then we still say no noises. And so I have shifted, honestly, in my approach, again, with the mantra of living and thriving. And, as a mom and a dad, in my case, saying that some of the things just are not possible, don't make sense. So this noise reduction and shielding, and then not treating the LQT2 child differently from a child raising disciplinary approach and so forth, thinking that we have to be white gloves with them, that maybe we've tilted too far to the other end. So where it makes sense, sure. A teenager with LQT2 waking up to jazz or classical music rather than a wow intense sound, yep, reasonable to do. Trying to putting your twins in different rooms because you don't want one twin to startle the other, I wouldn't do that. If you feel more comfortable, then you could do that. Then follow up, and Kate gets a 2-for-1 special today. Oh, it looks like she's going for 3, I see, but let's see. LQT2 adult taking a atenolol with no breakthrough for 25 plus years. Would I still recommend switching to Nadolol? Age 38, if that's relevant. Now, it depends. So what Kate is bringing up is, I don't like atenolol. I don't think that's a secret. It's not just my feeling. I don't think you'll find a single LQTS specialist in the world who likes atenolol, who uses atenolol preferentially. Do we have proof that atenolol is inferior, with proof being a randomized, blinded crossover study of Nadolol blinded, atenolol blinded, go 30 years and then see which collection of long QT people have less events? No. That study doesn't exist. It will never exist. But what I can tell you, we first sounded the alarm about the inferiority of the beta-1 selective beta blockers of metoprolol and atenolol almost 20 years ago. We published the paper 2004. Arthur Wilden and I published a follow-up paper in 2012, I think. There's been an additional paper since suggesting observational superiority of not Nadolol and propranolol. Now, you may have had no events on atenolol because you may well not need any therapy. Again, we now have about 100 patients with long QT syndrome who are under what we call intentional non-therapy, or maybe better referred to as preventative measures only therapy. So not starting the beta blocker or stopping the beta blocker. So it's impossible for me to advise, and I can't advise what you should do specific. I can tell you what I do when I see a patient who comes under my watch on long QT syndrome on atenolol. I first ask the question and do the size up. Does that patient need therapy? If yes, I don't view atenolol as therapy and I change their treatment configuration. If, on the other hand, I'm concluding that they may not need active therapy, that we can shift them to preventative measures only therapy, then either I stop their atenolol or I let them continue it, because then it's like not being on it anyway. And some of us emotionally would want to stay on something we've been on anyway, no harm, no foul kind of approach. Very involved, very complicated. Christian's pointing out that he found our side effect article while we were talking. And yep, thanks for posting that, Christian. And that's where we were very transparent of all of the encountered side effects. It kind of was, we got a lot of compliments from the scientific community saying, wow, you were willing to show the warts and wrinkles of our current therapies for full consumption. Again, noting that that spectrum of complications is going to be biased. It's going to be biased with more beta blocker complications, because that's why they came and chose Mayo, seeking alternatives. So when you look at that paper and see the number, that's higher than what reality would be if I was seeing all long QT patients as the first stop rather than as a referral stop. Kate gave me a follow-up response. Okay, so that wasn't a third question. So good on you, Kate, and all the best. Oh, Rachel's telling me that my wife's Instagram is private. See, I don't even know how Instagram works. But maybe I will take the video that she created of our son's solo flight on Wednesday and post it. Lene's giving a thank you, and you are most welcome, Lene. Love you and your family. And happy Mother's Day to you, Lene. And to all the moms. And I will wrap up with that in a little bit. But it says I still have 8 minutes. Click, click, click. Logan is next up. And multiple people in my family have long QT8, but not Timothy syndrome. Should we be concerned that they're still at risk for your kids could have Timothy syndrome? Oh, that's a great question, Logan. We could have a whole program on this, because I think we've been confusing out there. You see, there are many different genetic arrhythmia syndromes that a mutation in the CACNA1C calcium channel, that's the gene that builds the L-type calcium channel in the heart, and that calcium channel lives in other organs and other tissues, that certain kind of mutations, and the classic one is G406R, results in Timothy syndrome. And that is a complex multi-system disorder that affects not just the heart, but the digits, syndactyly, the endocrine system, tendency to low blood sugar, immune system, skeletal system, neurodevelopment, brain system. And so that's Timothy syndrome. Then there are other mutations in that gene that only affect the heart's electrical system, only affects the QT interval. That's calcium channel mediated LQT8. And importantly, if you are LQT8, you're not Timothy syndrome. You're not going to be Timothy syndrome. So it depends on what your mutation did to the biology of that protein, the L-type calcium channel. And so if there's no features of Timothy syndrome, you're only the heart, you're only QT prolongation, you are not Timothy syndrome, you will not be Timothy syndrome. You are LQT8, and we don't have to wonder, okay, when is neurodevelopment problems going to start happening? They're not going to. when is my endocrine system going to misbehave? It's not. And so I think that your question is such a good one, that we at SADS Foundation, we probably need to help give better clarity to the differences. And we have a wonderful alliance, the Timothy Syndrome Alliance, which is dedicated exclusively to Timothy Syndrome families. And we partner with them and have helped them launch. But there's a key and important differences. So Logan, I thank you for that. Coming towards the end, and Tara with a greeting. Oh, hi, Tara. Let's see. So one thing is, nobody got an okay from me for anything. So just remember, not delivering personal recommendations ever. Okay. Let's see. Where are we? Regina is asking a question, and it might take me too long to read it, but I'll speed read. The patient's father passed away while sleeping. So sorry about that. And the patient is a 42-year-old female, history of slow heart rate, bradycardia, right bundle branch block, went into VT, bottom chamber, fast rhythm, and was found after passing out 5 times with a heart rate of 260. Genetic testing revealed the sodium channel abnormalities, and as a result, you've been diagnosed with Brugada. Your 3 and 5-year-old daughters have tested positive for that SCN5A thing. Their EKGs are unremarkable. What are next steps? Well, there's a lot of things there, and that's going to take us past the 3-minute mark. But the point being, everything needs to slow down, and everything needs to convince ourselves, do we have truth? Is the thing that was found in the sodium channel gene a thing, like Dr. Seuss, thing 1, thing 2? Is thing 1 the thing? Is the evidence there to call it guilty as charged and name it a disease causative variant? So things that I would be doing in my detective work would be things like asking the question, is there any DNA retrievable available from the father who passed away at age 42 to see if he even owned it or not? Or are there any past records to see if his ECG ever showed hint of sodium channel disease? Can I make a link that way? If not, then we have to be super careful before we declare something guilty as charged. Because what you're describing with the patient, the 42-year-old female's presentation, is somewhat atypical of sodium channel loss of function behavior, although VT has been reported. But let's say we find and we conclude, yes, it's true. Then I would ask my question, has that variant been functionally studied before? Has it been proven to damage the sodium channel in a loss of function or a gain of function? So that could then further guide us. Then I look at who else owns the variant. And in this case, you're saying that the 3 and 5-year-old girls do, but that their initial ECGs are normal. Well, then I do a slow and steady follow-up. Would I see that your daughters every 3 months for repeat ECGs? No. Some people are doing that. Do I offer those families a follow-up assessment in 12 months or so? That's kind of what I do. And then we go from there to decide, do we have to give much attention to this at all? And you're most welcome, Kate. My pleasure. Last one is just to follow up that, Gina, I see your question. And your question is about talking to children about their disease. And you know what? It's so important of a question that I would like to have us devote a program this summer about what are anxiety relieving, anxiety reducing approaches rather than anxiety producing ways. There are important things we can do, And I would love to help equip you and all of our SADS community with ways to reduce anxiety. So I'm gonna take that as a charge, maybe not for the June 2nd program, which is going to be CPR AED awareness, but maybe the next one. And I'm going to work on that. And I'll have Aaron and Anna and the rest of Alice's team help us work with a focus on a program exclusively for your question, Gina. So I thank you for that one. Well, we're at the top of the hour. This brings Friday, May 12th, SADS Live 118 to a close. And for all of you moms out there, including this mother, the mother of our 4 children, and I love her. She's an incredible mom. Happy Mother's Day. Her mom is my mom, so happy Mother's Day to you. And for my own mom, happy Mother's Day as well. And for all of the moms out there, I wish you a special day. And I know I am well aware that for some mothers of the SADS Foundation family, Mother's Day is a reminder of how much work we still have to do, because your heart condition, your family's genetic arrhythmia syndrome was discovered from tragedy. And that tragedy may have been the loss of your child. And so for you, Mother's Day is a different kind of day, a bittersweet. There's still sweetness of the memories and just the treasured moments. But whatever your situation, happy Mother's Day. You are loved. You are loved by me and by the SADS family, and you're loved by our Creator who created you with a perfect plan. So until next time, be well. Have a wonderful Mother's Day weekend, and I will see you all next month on June 2nd. Until then, blessings, everyone.